Let's see. Okay, do you want me to go ahead and, oops, sorry, I gotta push. Do you want me to go ahead and get us launched then, Rebecca? Or do you want to give people a few more minutes to?
I am working on, you can go ahead and get us launched. For those of you that are on, I'm going to go ahead and end the poll. It is not like, it's just don't freak out if you didn't get a chance to take it. It's not the end of the world. The pre-test is also in the chat, just a few housekeeping things. If you can also go ahead and put in your chat your name and you know who you're with, your facility, whatever, in the chat box. We do appreciate being able to see faces. So if you're able and you're willing to have your camera on during the session, fabulous, do that. I will be monitoring the chat. So if you have questions as the speakers are speaking, presenting, you can type them into the chat and I will go ahead and find a convenient time to ask those questions. You also are welcome to ask if you can find a convenient time when I have that discussion. Welcome to, and then at the end of the session, I am going to put a post-test question. So the pre-test is in there now. At the end, we'll have the post-test. And then there are going to be 2 evaluation links. I also will be sending all of that out to all of you via email. So again, don't flip out if you don't get it via the chat, whatever, I do send it out to all the participants via email, along with the updated slides from today and the information. And then one last thing, we do now have the past videos of the past sessions in the series on our website. So you are welcome to go check those out. That would be a really great opportunity to see those. And other than that, we will go ahead and get started. I am going to turn it over to Meredith and Cindy to kind of introduce themselves and kick us off.
All right. Thank you. Yeah, great. We're happy to be here today. My name is Cindy Jutnan. I am here as a member of the co-director for the Mountain Plains Addiction Technology Transfer Center, which is a training and technical assistance center funded by SAMHSA, housed at the University of North Dakota. And we'll talk a little bit more about that as we get into it. I also serve as the Dean of the College of Education and Human Development at UND, and I am a licensed psychologist in North Dakota and have been since 1995. So I'm looking forward to talking today about stigma. Meredith?
Hi, everyone. Meredith Sjogren, also here at UND. I serve under Cindy on the Addiction Technology Transfer Center team, and I've been working in that capacity since we received the grant here at UND. I am a certified nurse midwife by profession, and so I have typically gotten to work with a lot of our topics related to pregnant and parenting people. And in addition to that work, I serve as the Dean of the College of Nursing and Professional Disciplines here at UND.
Great. Yay, so welcome. So what we'll be doing today is we're going to start by presenting some information related to stigma. Both Meredith and I appreciate questions as we go along. So if there's something that bubbles up that you want to discuss or take a few minutes, we've got enough flexibility in our presentation to do that. And then we'll be discussing some strategies you can use to address stigma in the second half of the presentation. So with that, I'm going to start sharing my screen. Okay, are you all seeing a slide that says words matter? Yep. Okay, great. All right. So just briefly a little bit, Meredith and I, as you said, we both work for the MPA TTC, and the goal of Mountain Plains, the ATTC system is to support and enhance substance use disorder treatment and recovery services for individuals in our region, Region 8, which includes North and South Dakota, Montana, Wyoming, Utah, and Colorado. We belong to the Technology Transfer Center Network, which is a national network of training and technical assistance centers that are funded by SAMHSA. This presentation was prepared on behalf of the Mountain Plains ATTC under a cooperative agreement from SAMHSA. All the materials preparing in this presentation, except those that are taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission by SAMHSA or by either Meredy or I. Although we do appreciate that you cite the source if you use this information. Please don't reproduce or distribute this without specific authorization, the distribution in its whole. At the present time, Miriam Delphin-Rittman is the Assistant Secretary of SAMHSA. The opinions expressed herein are the views of the presenters. This is Meredy and I, our work and our thoughts about this, and do not reflect in any way the Department of Health and Human Services or SAMHSA. And then we also want to talk, even though our topic is stigma, we also, and the power of language, we also want to acknowledge that across our presentations in whole, we really pay attention to the fact that language matters. Words have power. They have power to help, and they unfortunately have a lot of power to harm as well. So we will strive to use people first language, and we will strive to use language that promotes the promises of recovery by focusing on evidence-based and culturally informed practices. And we'll do our best to avoid language that minimizes those concerns or promotes feelings of hopelessness. Okay, so with that, we're going to launch into what is stigma. And again, feel free to use the chat or raise your hand to pose questions if you'd like to as we go along. Excuse me for this tail end of a cold here, which I hope won't give us too much problem. So stigma is a social phenomenon in which there is a negative attitude or belief that discredits a person or a group because of some attribute, which can include identity or it can include a health condition. It assumes that the person who is the target of the stigma will experience discrimination due to that attribute, right? SAMHSA defines stigma as the complex of attitudes, beliefs, behaviors, and structures that interact at different levels of society. So they can interact at the individual level internally, they can interact in groups, family systems, in organizations and agencies that provide services, and even at the larger systemic social level of policy and practice. And that complex of attitudes and beliefs and behaviors end up manifesting in prejudicial attitudes about and discriminatory practices against people with mental and substance use disorders. So stigma is essentially a socially construed and developed, socially constructed idea that's based on attitudes and beliefs that can end up putting people with certain attributes in a less favorable position and can shape the attitudes of others toward those people. And we see this play out in a lot of different ways when we're talking about mental health and substance use, as well as, and of course, when I shouldn't say mental health, behavioral health. So when we talk about substance use disorder, SUD, or sexually transmitted infections, STIs, we're talking about a set of behavioral health-related things that tend to be
all of your sweaters.
target.
Yeah, I was looking at your,
Yeah.
it's comfy.
Oh, sorry, I'll have to, there we go. Okay. All right. But that can act together to cause folks in those categories to become the targets of stigma. Stigma can get played out in a lot of different ways, but there's 5 basic types of stigma that are worth understanding. Public or social stigma refers to the public attitudes that result in discrimination or devaluation of an individual. Enacted stigma is the experience of discriminatory treatment by others. So there might be a public stigma that contributes to discrimination or devaluation, but then in addition, actions can actually be directly experienced by the person that's stigmatized, and that's considered enacted stigma. Anticipated or felt, closely tied, is expecting to be the target of discrimination in the future based on past experience. So if I go into a physician and I talk about having a sexually transmitted infection and the person does not respond to that well, there might be public or social attitudes, stigma that resulted, that triggered that response from the provider. It's enacted by the feedback they give me about my behavior. And then I may be reluctant to go back again because I'm anticipating or feeling stigma and I'm assuming I'm going to be discriminated against in the future. Systemic stigma refers to policies or practices that we develop at the level of, it could be anywhere from legislative level all the way down to individual practice level, that end up restricting access to care or resources because of a stigmatizing condition. And then finally, self or personal stigma is an internalization of negative stereotypes. So the individual starting to believe the negative and discriminatory beliefs about themselves that are being projected onto them from other sources. So these, of course, are not completely independent of each other, obviously. Even just that little example I gave, they interact with each other and they can be compounding, right? But together they can serve to keep people from accessing care and seeking out support and services. Now, there are many, many conditions that certainly experience stigma, but it's worth noting that addiction is one of the most stigmatized conditions globally. And this has been replicated a number of times. The most stigmatized is illicit drug use. Alcohol use tends to remain a very stigmatized condition. And it's important to note that the second most stigmatized condition in 2014 was being HIV positive. So sexually transmitted infections, STIs, often also fall into these rankings of stigma, high rates of stigma. Importantly for SUDs, there's been some research that shows that the long-lasting negative attitudes toward people with substance use disorder are reinforced through the media, which has a preponderance of negative perceptions that reinforce stigma. And when we think about the media, you can think about it from a number of different sources, but certainly in terms of like popular television, there's often a negative attributes are ascribed to people with SUDs. Also news stories and discussions, even like public service oriented and public health discussions often ascribe a lot of negative attributes to people with stigma. So that reinforcement then becomes both public social, but can also become even a structural kind of stigma because of the pervasiveness of that kind of media support. Stigma has been identified as one of the primary reasons that people with STIs don't seek medical care, and therefore the STI is not able to be identified and treated. Oftentimes, shame and embarrassment will keep people from notifying partners or notifying caregivers. And that's really important, not only in terms of treatment, but in terms of prevention. If people are feeling embarrassed or shame or stigma related to sexual behaviors in general, they're much less likely to seek out preventive measures, right? And so oftentimes people won't seek treatment until there's a lot more severity of symptoms. Garcia noted in 2021 that stigma is often amplified by public health policies and clinical procedures that separate people into sexual and behavioral categories associated with disapproval, rejection, and exclusion. And I think that that's really important thing to think about. Are there policies or are there procedures or practices in your areas of practice that will automatically include people in different categories or treat different diagnoses differently that might be attached to the presence of STIs? This kind of research really helps us look at and understand that systemic stigma and the ways in which it impacts people at an individual level. Okay, so excuse me. So really quickly, I'm not seeing any hands up or anything, but are there any questions about these general definitions or discussions related to stigma? No? Okay, all right, great. So the US epidemics of opioid and methamphetamine use have led to dramatic increases in overdose deaths, as well as an incidence of bloodborne and STIs. It's worth noting that one of the real reasons that we have to tackle stigma directly is that stigma is actually resulting because of the reluctance to seek help in higher rates of serious disease and higher rates of death by overdose and other means. So young adults who used an illicit drug in the past year were 3 times more likely to get an STI. So this is a really important interaction of these two areas. And shame, embarrassment, and the potential of partner notification can all help to deter help seeking. And I think it's important to acknowledge failing to seek help in one area can also contribute to failing to seek help in another area, right? These things don't occur separately. And the reluctance about people learning anything about a stigmatized health condition can cause people to be reluctant to seek help for any kind of health condition because that information may be revealed. Many people with substance use disorders experience coercion, violence, and discrimination related to their reproductive health. There's an entire field of study related to coercive SUD as part of domestic violence, where the coercive use of substance use disorders, which can be very, very subtle. It's not necessarily an issue of forcing someone to use a substance. It could be an issue of encouraging someone to use, even if you know they're struggling, or substance is always playing a role in issues of interpersonal violence. There's any number of ways. And we know reproductive health is also a tool that is often used in domestic and interpersonal violence situations. So the combination of using substances when pregnancy might be a factor falls into this domain of things as well. Many people have experienced unsafe sexual behavior in return for substances. So people who are seeking out substances or relying on substances may be asked to exchange that with sexual activity, which can lead to an increased risk of STI. And many have been forced into human trafficking as well. And we sometimes think about human trafficking as being a really extreme experience, but it is unfortunately far more common than we realize. And as we noted before, and I know I repeated this quote here, but I do think it's really important to note that when we think about these things in general, then stigma can itself end up both contributing to these problems and being amplified by public health policies and clinical procedures. So we really have to think about this as an interactive system that needs to be teased out. So why is there such a strong relationship between stigma in these two areas? Well, the biggest reasons tend to fall under blame, the assumption that people have caused their own illness. You know, you brought this on yourself. If you hadn't done this, this wouldn't have happened. So blame is a big factor in developing stigmatizing attitudes. There is a poor prognosis and a need for continued care. There's continued care, excuse me. There's a lot of public assumptions that both SUDs and STIs are going to be chronic, and that treatment is less likely to be effective, or that if you do have treatment, the treatment lasts a lifetime. And with that can come the idea that this is going to last forever. And so that poor prognosis and need for continued care contributes to stigma as well. There's a lot of social distancing that goes along with this. The idea that this wouldn't happen to me, or I would never want my child to date someone who had this kind of diagnosis, or the reluctance to form close attachments to people with these diagnoses is a factor. And then finally, fear. There's a fear that people with SUDs are dangerous. There's also the fear that's harder one to pin down that people often experience, that SUDs and STIs could happen to anyone. And that really ties into the social distance. But, you know, we're a good family. This would never happen to us is an important defense mechanism that people have related to STIs and SUDs. And so the fear attached to those contributes to stigmatizing attitudes and beliefs as well. The implications of stigma, well, the overarching implication is that stigma reduces human dignity, right? It causes us to other the people that have the identified condition. We might distance ourselves from them, we might marginalize them, we might isolate them in important ways, and both in terms of our public stigma, in terms of attitudes, and the enactments that feel like discrimination, people can become the other group, the group that we're taking care of, as opposed to a group that has equal human dignity. Systematic stigma violates the human right to care and concern because the treatment access to treatment is limited. The self-esteem and increased isolation that come from internalized stigma can actually amplify these other consequences of stigma, and anticipated stigma, because of the fear of discrimination, decreases help-seeking behavior. So that reduction of human dignity becomes sort of the mechanism by which these experiences of isolation are enacted. Once a person does engage in treatment for substance use disorder, it can also be a really good time to ensure that their reproductive health needs and sexual and needs related to STIs and other kinds of sexual behaviors are being met. The CDC promotes, and I've seen this promoted by a lot of community violence centers as well, the no wrong door approach, that we can provide or connect a person to all the services to meet their needs wherever they seek care. And that this kind of an approach is crucial to helping to minimize stigma and increase access to care. But we have to really then develop cooperation among agencies in order to ensure that that happens, right? So agencies need to be talking to each other and engaging with each other to ensure that we're making as many seamless referrals for care as possible across these areas. Okay, so I want to make sure that I don't jump ahead. Oh yeah, here we go. So here's a quick, very quick scenario. We're going to do a longer one here in the second half as well. Alice is a patient going to see Dr. Jones for an annual checkup. She's gained some weight since her last physical, and she's hoping to get some advice about how to adjust her diet. When Dr. Jones sees Alice, he says, "Oh, I see you've fallen off the sugar wagon. You know, at your age, you're at risk for type 2 diabetes if you can't get your food consumption under control. I won't be able to keep you on as a patient if you can't manage that." Now, what are your thoughts to this exchange between Alice and Dr. Jones?
Extremely inappropriate.
Extremely inappropriate. Okay. Yeah. Any thoughts about why it feels inappropriate from anyone? I don't want to put you on the spot, Lexi, or whoever that, I think that was Lexi.
Because it's really judgmental and it's not like a positive response to her wanting to better herself.
Right. Yes, it's definitely judgmental. And in addition to being judgmental, there's a threat in here. And what's the threat?
Losing the provider.
Right. Losing your provider. Right. Which a lot of us know how hard it is right now to get even a primary care provider, right? That's a big deal. Yeah. Other thoughts from folks?
I think a lack of education for the patient,
The lack of education.
not referring her to somebody that potentially might be able to register dietitian or someone that could give her some support
Right.
with that. So
Right.
that would be the first thing I would think that a provider would do.
Right. And, you know, type 2 diabetes is very common. We know that, right? And we know that there are a lot of other professionals that can help somebody with that issue, don't we? I mean, that's pretty common. It's a pretty common thing to hear for a lot of people once they're in their 40s and 50s, right? Would you be surprised? Would you be surprised if a primary care provider made this kind of reaction to somebody that might be borderline with type 2 diabetes? Would that surprise you at all?
No, it doesn't, especially if the person is fat.
Okay. Okay. Because fat is also, we know, a stigmatized condition, right?
Yeah, I was gonna say,
Yeah.
I've had almost a very similar conversation before from a provider.
Okay. Okay.
There are
And shaming
people,
for her. I think, you know, she came in probably already realizing that she had gained weight and was looking
Right.
for some guidance, and then, you know, got the shaming.
Right. Right.
there are two answers in the chat box. One person said, "How rude." And then someone said, "It doesn't take into consideration what life stressors might be present at the current moment."
Sure. Right. Yeah. And, you know, we can read this and we can go right away, oh my gosh, here's somebody coming in knowing that they're going to need help for something to prevent a potential medical. I mean, you know, she knows she's coming in saying, hey, I need some help adjusting my diet, right? She's coming in prepared for that. And then to get this kind of response would be really shaming, right? It is discriminatory. We don't know how much weight she's gained, but you know, but we know that fat shaming and fat discrimination is a real thing. So there's all kinds of things happening here. Now, if we think about this in the context of somebody who has an STI or a substance use disorder, right? And they're going to be coming in and talking about not weight gain, but about sexual behaviors or what kinds of substances they're using. How might this same kind of conversation play out? I would argue that unfortunately, it's maybe even more common in those areas, right? I know that there are providers who will say, I can't treat you until you've got your substance use under control. I need help getting my substance use under control. You know what? Who can help me with that? Well, unfortunately, there's a shortage of addiction counselors, so I'm not sure. Oh, well, can I get help with anything? I mean, these are the kinds of things, these are the kinds of attitudes and behaviors, right, that can really translate into direct, not only worry about future access for care, but immediately feeling like your access to care might be cut off. So great. Okay, good. So the other thing it's important to know is in all these situations, and somebody already mentioned life events, and that's an important one, but also stigma is intersectional. So we have to pay attention to the fact that as back in the definition of stigma, we talked about that stigma is tied to personal attributes, not just diagnoses, but attributes, right? So stigma can intersect with gender, with age, with size, with sexual orientation, with race, with class, all kinds of social identifiers and personal identifiers that people might use, right? And so people might have a different reaction to substance use from a man or a woman, right? They might have a different reaction to age and STIs or a combination thereof. Racial beliefs and discrimination related to racial identification might come into play and make stigma greater, right? So this is a really important thing to keep in mind about stigma, is it can be happening in the same, we can have two people, we can have a dyad of people, and it could be happening at different levels in their conversation. And so becoming aware of that and becoming attuned to what stigma might be playing out is so critically important. One of the best ways as professionals that we can reduce stigma is by making sure that we use language that helps, well, internally, we need to process, like I said, our own awareness of it. But in addition, in our interactions with others, we need to use language that's person first. We need to use objective terms rather than those that are value or morality-based words. Like even in our little example with Alice, a question about, well, let's talk about how much sugar you're consuming is very different from, oh, I see you falling off the sugar wagon, right? Like there are very different ways that we can talk with people that will make a big difference in terms of stigma. We can avoid fear-based or sensational language, and we can avoid slang or derogatory terms, right? So as some examples, really avoiding words like addict, junkie, pothead, alcoholic, words that put the definition or use factor before the person. And really working with person with an SUD, such an important change. Focusing on testing clean or testing dirty, being clean, sober, on the wagon, drug abuse, addicted babies, addiction is lifelong battle. These are all terms that can bring with them stigma and problematic attitudes. So we want to avoid those and instead focus on positive or negative tests and much more objective. In recovery, demonstrating of the positive process, misuse or use of drugs, a newborn who is exposed to substances as opposed to highlighting the addicted part. And then SUDs can be treated. Even just being able to say to people, SUDs can be treated, STIs can be treated. You can work with this diagnosis. Even something as straightforward as that can make a big difference in terms of the kind of language that will help us mitigate the impact of stigma. Okay, so now I am going to Verity, in the interest of time, should we just roll over into yours so that you can get quickly into the application? Does that make sense?
Yeah, that's
Okay.
no problem. And I'll just ask you when I'm ready to switch, if that's okay, to the next slide.
You bet.
All
Yep.
right, perfect.
Perfect.
Okay, so as you've all been listening to Cindy's words today, and we've increased our awareness of stigma, my guess would be this: you're starting to think about the things that you can change personally. This is how I can enact this information and how I can change if I am potentially using stigmatizing language. But the other layer to this, as healthcare providers, is that we need to really be cognizant of what's happening in our workplace. And so it's a different kind of stigma that can be there, similar, but it affects a broader concept, and it affects the entire place of work that we're looking at. So we readily acknowledge that when we care for people who are impacted by substance use disorders and sexually transmitted infections, it can be challenging. We have personal biases, as Cindy pointed out. We also have a lot of misinformation that's out there, but we often will also hear conversations that are going on in our workplace that are very disrespectful and judgmental, that add to the conflict that we have in the moral distress. So we can change our personal behavior. We can address how we talk with our clients, but how do we acknowledge the stigma that's collective in the workplace, and how do we confront and talk to a peer or a colleague who's in the workplace for us? So what we'd like you to consider next is consider the language that we use when we talk with our own work colleagues, and then think about tools or ways that we can create a healthier dialogue to redirect any stigmatizing conversations that are impacting our place of work. Next slide. So before we talk about this particular tool to address workplace stigma, I'm curious to know if any of you right off the bat, before even getting into a case that we're going to talk with you about today, can think of an instance and are willing to share that instance where you have experienced peers in your workplace using stigmatizing language. Is anybody willing to share that? So maybe you've heard a colleague, you've heard somebody at a front desk, you've heard conversations in the lunchroom of people maybe talking about clients or are using stigmatizing language.
Hi, this is Jennifer. I'm a field epidemiologist for
Hey.
the State Health Department. I was recently on a phone call with a peer, but not one of our state agency members. And we were discussing testing for STIs, hepatitis C with at-home collection.
Okay.
And my peer indicated that they didn't think that would work for substance use disorder individuals because they didn't think they had the mental capacity to be able to do that testing at home.
Yes. Yes. Can I ask if anybody called out that statement during the conversation?
It was a pretty small group, so
Okay.
no one was really quite brave enough because we were still
Sure.
trying to wrap our heads around what was being said.
Thank you for using the word brave, because it's one thing we think about how we change our own dialogue, but it does take somebody to be pretty brave to be able to talk to a group about something that's there. I would probably guess that many of you were thinking about that conversation once it ended, but not sure how to approach it in the workplace. Really good example. And the case that I'm going to share with you actually comes from a practice experience I had as well. So anybody else who wants to offer up a scenario or an example where they've seen this happen?
Ada, I actually was presenting at a conference, and there was a mixed audience of providers, first responders, and it happened to be that I was presenting on medication administration treatment. I think that it's a lack of knowledge of what words to actually use, and I think that and the reason that I'm on here today is to find ways of being able to educate people that I work with, because I don't think that, I mean, there's some blatant, obvious words that we are hearing right now that are very stigmatizing, but I think that for a very long time we've used language that we didn't think was very inappropriate, and it was very inappropriate. So I think that you guys doing this is awesome, because I really want to be able to find ways to educate on stigma and appropriate use of language and words, so that as we go forward and we're in front of more people, especially those of us that have the opportunity to engage in public forums, that we're able to give the correct language that makes things appropriate. So thank you very much.
Sure. Absolutely. Okay, so as we move on now to talk about this particular tool, to kind of give you an idea of how to address stigma in the workplace, do think of your own workplace and other things that maybe you didn't want to share today that you're thinking, wow, this could have been a pretty good example. So I came across this particular work when I was doing some research for a presentation that I was pulling together that specifically addressed the stigma that pregnant and parenting people experience when they have a substance use disorder. And this particular tool was developed to address peer attitudes in a NICU setting, but I have found that it is really adaptable to many other situations and scenarios, and it's short and concise and easy to remember. So you got to love a good acronym when we're looking at these kinds of things. So this is called the ACTS tool. It's a guided script to help you find the words to respond respectfully and constructively to your colleagues when you recognize that stigmatizing language is occurring, or even actions to be there. So next slide, Cindy. So the first step in the ACTS tool is actually the word acknowledge. So we're going to talk about how do you acknowledge the statement that you heard? How do you create this opportunity to open the dialogue and not criticize? And then we'll move on to create a circumstance for reflection where you can think out loud or ask questions of the situation. And we'll go to the next slide. The third letter stands for teach. And so we're going to ask our permission to share some knowledge about what we've learned. And then finally, how do you kind of close the loop or provide that support in the setting? So how are you encouraging your peers to take a new approach? How do you identify the courage? Somebody mentioned the word brave, the courage to actually suggest these changes. And then how do you celebrate those successes? One particular line on this slide, identify the moral courage to try a new language. I really liken this to if any of you have learned to speak Spanish, French, something other than English. Can you think about when you tried to use, so I could think about when I was trying to learn Spanish, the first time I wanted to publicly use a phrase in Spanish, I was just nervous. I'm going to say something wrong. I'm going to say something inappropriate. It's not intentional, but it's how it's going to come out. So when we started applying the ACTS tool, it really is like learning a new language. When we try to substitute stigmatizing words for non-stigmatizing language, it is new. It's new to us, but it takes practice, and with practice, it can be very successful. Okay, next slide. Okay, so this scenario, I'm going to give you a little context. In my work as a certified nurse midwife, I spent a lot of time in family planning. Actually loved this part of my job, worked with so many great people, but there's an opportunity there for a lot of stigmatizing language that can happen. There's an opportunity for people to be terrified to come in for care, and there's a really big opportunity for us to do this care, provide this care well, or we will not see people returning for their care. Okay, so I want you to think about Jane. In this particular setting, people came up to the front desk, and there would be two separate front desk people where you could walk into to do your intake, or I'm here for my appointment, and they take your basic information before you sit down. Also think about how those front desk scenarios changed with COVID. So now this practice setting has the plexiglass that's up there. And as a result, people have to talk a little bit louder when they introduce themselves. My name is Meredith, I'm here for my appointment. And so things are overheard a little bit differently. And anytime you have to speak a little bit louder, I think that potential for embarrassment is also there when you're checking in for this appointment. Okay, so Jane's 32. She came into a community health center where she'd been actually receiving treatment for her opioid use disorder. And she'd been a client there for about the past 10 months and was on buprenorphine. She was doing very, very well in recovery. And she was now coming in for just a monthly appointment to check in with her provider. When Jane checked in at the front desk, she asked if her provider would have some time to also see her for a new concern that she described as burning with urination. The receptionist, who had been with the healthcare center for only about 4 months, rolled her eyes and said, "You know, they're really busy. They probably aren't going to have time to add that on. So maybe you should just go to the free clinic for that." Jane looked incredibly embarrassed, and she took a seat in the waiting room, but did stay. The receptionist called the nurse on the phone to say, "Jane is here. Sounds like she's been really busy and wants an STD check. She's probably using again too, if that's what she's worried about." The office manager overheard that phone conversation. So, first thoughts before we talk into how to address this. Has anybody experienced anything similar to this? Heard anything similar? Probably really not wanting to disclose if your workplace has had something similar to this. Okay, let me take it back. If you think back to Cindy's words, what kind of stigma is actually going on here? Any thoughts?
Well, they're basically putting her in a box that she is, in order to sustain her drug habit, that she is promoting herself in a very promiscuous way, which you don't know that based off of her telling you that at the reception desk.
Okay.
That's you're blatantly, in a very rude, disrespectful way, categorizing her and putting her in that box.
Right. Do you think there's any type of stigma that could have influenced this receptionist's language?
I think the difficult part is with the clientele that we see is supporting their self-efficacy along the way in their recovery. Like, if they do relapse, still supporting them that they can change and just meeting them where they're at the entire way. And sometimes that's taking away our own viewpoints as professionals working with them in whatever capacity we are, and that, you know what I mean, that taking that away. So they could have came, you know, Jane's been there the past 10 months. This receptionist has been there for 4 months. you know, she obviously has kind of a preconceived bias herself. And
Yes, so I want to catch you right there with the preconceived bias, that often that comes from that public or systemic stigma that is out in the communities that influences us. So she might have her own personal biases, and one could probably
Right.
argue, why would you take a position if we're working with clients with substance use disorders and STIs, if you haven't become aware of your own personal bias? Maybe she didn't become aware of her bias until she started working there, but really think about that influence of public and systemic stigma and what that brings into the workplace. Okay, so let's go on then to the next slide. And then let's take the first step. So how do you acknowledge the situation and start the conversation with your peer? So if you were the office manager and you heard this, how would you start this conversation with the receptionist? Would you? Would anybody want to start this conversation, or would everybody say, nope, not me?
We had in the chat saying the receptionist should be reminded about workplace stigma and that they are not to be making any assessments themselves, as it can influence the provider's perception when meeting with the client, review receptionist jobs, duties, and workplace behaviors.
Okay, so that response covered a lot of the whole ACTS tool. That's right. So the first, if we want to just acknowledge it, you basically, this frame was coming from the perspective of job duties, responsibilities of that person to be able to be there. So next slide, here's a suggestion. So one way to acknowledge this would be not to criticize, take an opportunity, and maybe think about when you could catch this person privately and just maybe around the corner at break and just say, hey, can we talk about this morning? I was surprised to hear you talk about Jane that way to the nurse. She's been doing so well and is always so kind to everyone when she comes in. She's been in recovery for 10 months. So this is one way to acknowledge it in a non-threatening way, but just say, hey, I heard what you said, and really find the positives. This is somebody who is consistently coming to the clinic. They're in recovery. And maybe it's just a way to start having this conversation and take a pause to see what the receptionist would have to say next. Okay, next slide. So then asks you to create a circumstance for reflection. And so this could be where you either ask a question of your peer or you think out loud a little bit. Any suggestions for how you could create that reflection? Something you could say to help her think about her words.
I would probably ask them, or I'd probably give them some examples of more like positive or strengths-based approaches that they could use, and then ask them to put it in their own language just to give me an example. But I'm thinking of, so I'm sorry, I didn't introduce myself either and I got on late. I'm Avalon Valencia. I work for a nonprofit like health clinics. I supervise a health equity program, but prior to this, I worked strictly in a clinical setting that served a variety of mental health needs and substance use. There's a lot of coordination in there, but when I worked at that clinic, there was a lot going on with stigma. But yeah, I would, and I did this often, I would bring it back to our staffings, like our staff meetings, and just kind of open things up for a discussion and just let everyone know that there's like different feelings that we all have based on our own experiences, and that awareness of it is something that we'll continue to practice.
Okay, all right, very good. Okay, so Cindy, if you go to next slide. So one suggestion I have for helping them reflect upon what they said, because a lot of times when people are using stigmatizing language, maybe they're not recognizing it as stigmatizing. So it'd be, could you just share with me why you thought Jane had an STI and wasn't maintaining her recovery? We really need to make sure we aren't assuming anything with our clients, and it can stigmatize them unintentionally when they're here. So clarifying why she thought that, maybe she had an experience in a previous workplace, maybe that's how she had been talked to, maybe that's was part of her background of what she's heard or used the language that's been used before. Okay, so then we'll move on to the third step, which is teach. So asking permission to share some knowledge about what you have learned. Has anybody had an opportunity in the workplace to share something with their peers? An article, a webinar, a video, anything that they've learned from somebody else about stigma. Anybody out there? Okay, all right, so then let's go through the example that I came up with based on the real world. So sharing an article or evidence-based information. At this particular clinic, I knew that they had had a recent webinar on stigma, and I know that because I had given it. So obviously it wasn't working so well in this case. So one way to approach it was, did you happen to listen to the webinar training our director sent out about stigma? The speaker talked about how important our language is when we talk to clients, and how if we use stigmatizing language, we might actually prevent clients from getting the care that they need. May I share that link with you? Now, this was a relatively new employee, talks to the value of always making sure when we're onboarding employees, if we include some type of training on stigma, which would be very, very appropriate, to make sure that they've actually seen that information and had an opportunity to ask any questions about that information. Next slide. So once we have done that, we want to support our peers to be able to try a new approach with their client and then be able to talk about or debrief the approach that they used and how do we celebrate their successes. So I think we'll just go ahead and finish up. Cindy, if you want to go to the next slide. So one of the examples that I did included here was what we actually did in this particular setting. So knowing that there were some people who probably hadn't heard the webinar, asked the health center director to host a lunch and learn about stigma. The team listened collectively to the stigma webinar and then talked about how they could address clients when they come to the center for their care. The next time Jane came in for the appointment, happened to be close to the front desk, and I noticed that the receptionist used eye contact with Jane. She greeted her when she came in, and she asked her how she was doing. Jane returned the smile and looked visibly relieved, and later had the opportunity to visit with the receptionist and tell her what a great job she had done. Wondering if you think about the line, Jane returned the smile and looked visibly relieved. What stuck out to me about Cindy's words were that this is an example of somebody who probably anticipated experiencing stigma by coming back to the clinic. So very easily, this could have been a person based on the scenario that said, I'm not going to go back there. I'll just, it doesn't matter, you know, where I'll just find somebody else to prescribe buprenorphine. Yep, I'll just go to the free clinic. It's the only place that somebody wants to see me. But this is a person who did come back and therefore provide the workplace an opportunity to correct the language that was used previously. So always think about that internal anticipatory type of stigma, that it's pretty scary for somebody to come forward into receiving care for substance use disorders and STIs. So this was an example where it actually turned around pretty nicely. Okay, so I think that'll take us to the end of this content, and happy to talk about the scenario a little bit more, answer any of your questions, and we'll take time to do that now.
You know, one of the things I'll just throw out there just to kind of get us started is, you know, when you think about that tool that you're talking about, Meredy, ACTS, like, you know, it's very simple in lots of important ways. It is about that developing the courage to confront the discomfort of not even challenging someone, but kind of holding up a mirror for them. Yes. To help them see how what they're saying might be experienced by other people. And once we can get through that discomfort, then this is a really straightforward set of steps that are very practical, which is what I really love about that. Yeah.
Yeah, and the shorter, the easier it is to remember and take through the steps, but also talks, you know, really talks about that if we're going to get to that place where we can teach our peers, to making sure our workplace has resources readily available to address stigma. So as I said, we're all probably taking this internally and thinking about our own personal language and how we can change and make sure we're using appropriate language. But when we go back to our work settings, do we have the resources there that can address the collective organization?
Well, and it's to tag on to that, it's really powerful if you all know, if you all can use this kind of approach for yourselves internally and be transparent about that and share it with your colleagues, it makes it much more likely that your colleagues will also hear when you say, hey, what about this?
Yes.
You know, that's scary too, but important. Yeah.
I can share that in a previous position that I recently just left, it was actually a city initiative to make sure that we were educating. And we actually did a promotion of hashtag shatter the stigma. They actually made that we had grant funding, that we actually made billboards, posters that went up on all city buildings. And through the opioid coalition that we had within the city, we were promoting and educating younger people. So middle and high school, we were doing the Arts 360 training and making sure that we were providing counseling and support for our community. But one of the things that we did do was we went to the extent of actually making posters that said hashtag shatter the stigma. And it was an actual movement to help educate and promote supporting the families and letting them know that, and in this particular scenario, it was for opioid use disorder, and educating on the risks of how easily everyone could be addicted in any manner, whether it's alcohol, a substance abuse disorder does not discriminate, especially opioid use disorder. It doesn't matter what socioeconomic background you come from. We are seeing it in every socioeconomic level. And so we did lunch and learns just as you did. We educated on what withdrawal looked like, what addiction was, what opioid use disorder was, what alcohol use looked like, how to identify things. But the big thing was the movement of actually promoting and using grant funding in a positive way to spread the message and provide resources. There was QR codes onto those billboards and QR codes onto all of those posters that were disseminated within the city, within the schools, and on those billboards. And it really helped because we were able to track the amount of people that we were able to connect with, but it also gave a list of resources where people could connect to getting help. But the big thing was hashtag shatter the stigma. And that was the big thing, is that we wanted to make it available, not only just to one sector. And many of us are working directly with those, just as I am now, directly with those with opioid use disorder and trying to get them connected in MAP programs or MAP programs and things. But really that initiative within that city and promoting that there is absolutely nobody that's being that should be discriminated against, because it affects our entire communities. And so spreading that word, education, and making it more of a movement was a really, really good way for us to be able to try and spread that word. So I think they took it a step further. I was really proud of the work that we had done in the last year on that, and they continued to create and they got additional funding just because of the amount of traction and numbers that we were able to reach for people. So I would encourage highly that it doesn't seem like this at first. The idea was like, well, do we really want to spend money on this? Would it really send a message? And we got a lot of really positive feedback from it. So I just want to encourage everybody that this really does work. It really does help, and it really does allow for those that are trying to seek assistance, help, and support for those that have families or children that they are not sure if they have any type of an issue. Earlier intervention and earlier support is the key to getting the help that they need before we get into a situation where we're looking into our jails, we're looking into that high risk population. At that point, we're already so far into it. So really trying to do things on the prevention and educating even those that may not have yet been touched by any of these things, and shattering that stigma and helping. It might be a neighbor of theirs, maybe not a family member, but really kind of spreading the word. And this movement really went a long way. So I appreciate your guys' work and everybody that is on here. The work that you do every day really does matter.
Okay. Any other comments or questions? Any other pieces?
I did see someone put in the chat box that from the scenario, it seemed like the receptionist had violated HIPAA by assuming and discussing with the nurses over the phone, and she was overheard. Can you talk about that?
Well, I think at many different levels. Again, when somebody comes in to check, those conversations shouldn't be had at the front desk. It's not unusual for a receptionist to let a nurse know that a client is ready to be taken back. But yes, there's no need for them to go into phone conversations to do that. It certainly could have been done a one-on-one. A person is added for or requested an extra service for it to be there. But yes, all of that needs to be addressed. It's really difficult to check in at any front desk for any facility, because very rarely will you find it soundproof for somebody to be able to do that. Interestingly, when family planning services are offered within a primary care setting too, they try very, very hard to make sure that nothing looks different. So everybody checks in at the same desk. You wouldn't want to have only this lane is for somebody checking in for family planning, and this lane is for somebody for everything else. And so everybody's mixed in when they're coming to the front desk. I think it's also a lack of education. On the part of the client, they probably didn't know how do they request this. They didn't want to wait till they got back to the room, probably knew that it would be something that would take extra time, but they wanted to be addressed. So that may not have been intentional on that part, but could it have been handled differently? Of course. And just so you all know, no STI was there. We had just a very basic UTI in the situation.
I have a stigma story that I can share.
Sure.
So we present for my program, the brain injury program, we present as part of the critical incident training, kind of the crisis training for police departments across the state. And we were presenting at one of the police departments. And when we do that, we always invite a survivor to come with us and present with us. So one of my staff was doing that and was going, and she had picked up the survivor, and they had lunch first, and then they went to do the training. And while the other speaker was speaking, they were kind of setting up things and whatnot. And somebody came up to my staff and said, you know, my coworker, and said, the woman you're with is high. She can't present with you. And so my coworker was really kind of shaken up and said, you know, no, I know her. What do you mean? And they were like, no, she's high, and it's going to ruin your reputation if you have her present with you. And so she calls me and she's like, I don't know what to do. And I'm like, well, do you think she's high? And she's like, no, but I've only met her over Zoom. I've never met her face to face. And then I said, well, is there anybody else in the room that maybe knows her? Who is it that made the accusation? Anything like that? So my coworker just kind of told her, like, here, hang tight. You finish setting up the handouts and I'm going to go talk. And so she went and talked. Turns out it was the administrative assistant at the sheriff's office that had made the accusation, but she didn't really know her. So my coworker talked to, some other people and actually found a detective that was a part of the training that had worked with the client in the past, knew the individual, and was willing to vouch for her and said, no, this is the way she is. She's not high, everything's great. And they were able to move on and present that day, and it was fine. And it actually worked out because they, part of the presentation was showing that this is how she presents, because of her injury, she presents hyper, she's, very verbose, all of those type of things that you may trigger this way. And so it was really good. But my coworker had making sure that the client never kind of knew what was going on. Like, she kind of had an idea, but never really let her know the inner details. And so, but then afterwards, it was, the client actually came forward and said, well, what was going on? What was what was all the secret conversations? And so my coworker came clean and said to her, well, they had accused you of being high. And, and the client said, well, what? And she pulled down the mirror in the car. Did I look like I'm high today? Like, what did I do wrong? And and so it was part, and then part of it having that stigma conversation with that client to make sure it didn't set her back, like letting her know, but you still were able to go on and do a great presentation. But also then it was following up and working with that, that police department and that, around their stigma. And that was the whole purpose of that training that day, was to be bringing in more information and kind of breaking the stigma. And then right there during that, we faced that. So So it's definitely, and that client actually just won an award at our conference last week. So she was our Volunteer of the Year award. So so she was able to move on and overcome that, and now kind of works it into when she talks about things. But it definitely was upsetting at the time.
Yeah, I'm sure. And it just highlights how insidious this is, right? Like, it's everywhere. Stigma's everywhere. Just, it gets tapped all the time, which in a way can help normalize the challenging it. Like, it happens all the time. So all of us have to be engaged in this process. Yeah,
exactly. Well, thank you very much. It was a wonderful presentation today. Really enjoyed it. I did put the post test and the 2 different evaluations in the chat, but I also will be sending them out via email. So if you didn't get them, you can get them after that. And we really look forward to our next session is on April 12th, where kind of follow up to this, Dr. McLean is going to talk to us about the overlap between law and ethics and what do we do when conflict does occur. So thank you, everybody. Take care.
Thank you.